So we'll talk today about the care of patients on mechanical ventilation. So our objectives, it's the communication and check ventilator settings and parameters, the suction appropriately, assist the pain and sedation needs, prevent infection, prevent hemodynamic instability, manage the airway, meet the patient nutritional needs, wean the patient from ventilator appropriately, educate the patient and the family. So the first one, we'll talk about the communication. The communication among care providers promote optimal outcomes. So the most important things, the communication between the healthcare providers and the patient. To make sure you are aware of the team members' communication about the patient, and communicating with the patient is essential. Therefore, it's necessary to provide communication tools so the patient can express the needs. Also, the healthcare provider can ask the simple questions to the patient. For example, the questions, the answer, it will be with yes or no, so you can understand the patient, what he want or what he need. Second, check the ventilator settings and the modes. So we'll compare the current ventilator settings with the settings prescribed in the physician order, such as the mode of ventilation, tidal volume, and respiratory rate, and I time and IE ratio, and PEEP and FiO2. So we will compare, for example, the FiO2, it was before 100, then decreased gradually from 100 to 60, 40, so it will be to the low settings. So there is comparing between our settings before when we hook to the ventilator and the patient after 1 day, 2 day with the mechanical ventilator. The third thing is suction. We should suction the patient appropriately. The application of negative pressure to the airways through collecting the tube. Suctioning can be performed with to the upper airway through the mouth or the lower airway through the trachea. So the tracheal suctioning through the mouth should be avoided. Why? Because we might cause gagging to the patient, then the patient might vomit. So when we will do the suction to the upper airway through the mouth, it should be gently and prevent the gagging. We have two techniques of endotracheal suction: the open suction and the closed suction. The open suction, it should be sterile technique, so we will wear sterile gloves and we will disconnect from the ventilator. So we should pre-oxygenate before that, then with the sterile gloves we'll apply the suction. The closed technique or the closed suction technique, it's already closed inline suction catheter attached to the ventilator circuit. So we cannot disconnect from the ventilator while giving the ventilator the breaths and tidal volume. We can do the suction without any interruption. And this way it's more safe to the patient and will prevent from the infection. The general suction recommendation, suction only as needed, not according to the schedule. So we should assess the patient for the suction. Does he need the suction or not? So we'll auscultate the patient, we'll see the monitor of the ventilator, we'll see the no resistance, PIP, peak inspiratory pressure, it's normal, not high. So we'll ask ourselves, do we need after our assessment or not? And we should hyperoxygenate the patient before do the suction to prevent the desaturation. And also don't instill the normal saline solution into endotracheal tube in attempt to promote the secretion removal, unless if really needed, so we can give a minimal amount if we have a thick secretion. Limit suctioning pressure. We have a pressure for each year for the patient. For example, the levels for the neonate from 60 to 80 and infants 80 to 100 millimeter of mercury, and children's 100 to 120 millimeter of mercury, and the adult 120 to 150. In the other box, the infants with including with the neonate, so it's 60 to 80, and children 80 to 100, and the adult 100 to 120. Section for the shortest duration possible. So we will not exceed 15 seconds in all our procedure for the suctioning. So 15 seconds, we'll apply the suction. After that, we'll stop, test the patient, then monitor the vital signs if it's stable, so we can apply the suction again. So use the subglottic suctioning to reduce the incidence of VAP. The subglottic suction, it's above of the cuff pressure in the endotracheal tube, it will be above. So this benefit of subglottic suctioning to reduce the incidence of VAP, which is ventilator-associated pneumonia. Will assess the pain and sedation need. We have two scales that help to evaluate the patient's sedation level, are the Richmond Agitation Sedation Scale and Ramsey Sedation Scale, and it's 1 to 6. It will check the patient level of consciousness, how conscious is he, he's on sedation or not, he's following the orders, he can blink his eyes, his sluggish response to the light or not, or no response. So all this one, it might affect on our weaning criteria. Prevent the infection. So how we can prevent the infection? The ventilator-associated pneumonia is the major complication of mechanical ventilation. How we can prevent that? To keep the head elevated 30 degree. We'll keep the head elevated 30 degree to 45, mostly on 30 degree. It's acceptable to the patient. Every day provide sedation vacation, assess the readiness to extubate the patient. Also provide peptic ulcer prophylaxis, provide deep vein thrombosis prophylaxis, perform oral care. So we'll do the oral care to the patient daily. If he needs to suction or no, we'll clean the mouth, we'll clean everything around the mouth. Also use automated subglottic suction, the most important thing. Prevent hemodynamic instability. So how we can prevent hemodynamic instability? We'll monitor the blood pressure continuously, typically after the ventilator setting change or adjusted, because the ventilator, it's a positive pressure. So this positive pressure, it might increase intrathoracic pressure, which has determinantal effects to the cardiovascular system. Also the PEEP, positive end expiratory pressure, when we will increase to the high number, it might affect on the venous return. So we will check the blood pressure continuously and monitor the heart rate, saturation, everything. Manage the airway. Proper endotracheal cuff inflation to prevent the leakage. In turn, ensure that patient would receive preset minute ventilation. So we should keep the cuff pressure inflated in a good range, which is 25 to 30. Some of the books, they will say 22 to 30. We will not overinflate or more deflate, so it might do leak on the ventilator. So we will give the patient his target tidal volume and the minute ventilation. We'll make sure no desaturation. So very important to check the cuff pressure leakage. Meet the patient nutritional needs. For optimal outcomes, ventilator patient must be well nourished. For sure, they should have feeding tubes with a liquid nutrition provided through the gut. Wean the patient from the ventilator appropriately. Weaning protocol should be used to guide the ventilator withdrawal. Therefore, the healthcare provider needs to perform the following: daily patient screen for readiness. So we'll check everything, the labs, the spontaneous breathing trial, and the apply extubation criteria. So first thing, before we'll do the spontaneous breathing trial, we should check the extubation criteria, which is the NIF, negative inspiratory force. So it should be at least negative 20 to check the patient readiness and the muscle strength for the patient. And RSPI, the rapid shallow breathing index, should be more than 105. And cough, patient should have a good strong cough and gag reflex. The GCS should be patient aware and awake and conscious. So the patient, he can follow the orders. For example, I will ask him to raise his hands, right hand, left hand, so he's oriented and he can follow the orders. After that, if all these criteria fit and patient on low settings, low FiO2, low rate, is having tidal volume, that time we put the patient on CPAP mode or weaning mode. They call it pressure support ventilation or PSV. Some of the ventilators or companies, they have CPAP mode or spontaneous mode. So it depends on the company. So the SBT or spontaneous breathing time should be from 30 minutes to 120 minutes. After that, if the patient met all the criteria, patient is conscious, the NEF more than 20, RSPI less than 105, patient having good and strong cough and gag reflex, GCS, it's good. After that, we can extubate the patient and remove the endotracheal tube from the patient. Educate the patient and the family. Caring for a patient on mechanical ventilation requires teamwork, knowledge of care goals, and interventions based on best practice, patient needs, and response to the therapy. Mechanical ventilation is widely used as integral supportive tools for wide categories of the critical care patient. Nurses also should be knowledgeable and confident in caring for the mechanical ventilated patient. Thank you.